To talk a little bit today about what DataLoch is, how we fit into the wider health ecosystem in Scotland, and how we support research. So that's the plan today. And I've got a couple of examples of the research that has used some of the DataLoch data to support it a bit later on. But first of all, what is DataLoch? So, DataLoch is actually a partnership between the University of Edinburgh and NHS Lothian. We are a data service. We aim to enable health and wellbeing improvements in this region and beyond by bringing together routinely connected health and social care data for the Lothian region. We then work with health and care experts to improve the quality of that data and to document our understanding of it for researchers, and then provide safe access to extracts of this data to academics or clinical teams or to innovators, policy leaders, etc. And we do so within our trusted research environment. Or TRE. And a TRE is a lockdown environment where analysts can access the data. They come to the data, they can use the analytical tools within that space, but they can't then remove the data from that environment. So all of the research that we support is supported through TRE. We're accountable to the public for how we use that data, and we have a public reference group that's part of DataLoch that help us understand public perspectives about how we do this, the projects we serve. So that's DataLoch. How do we fit into the wider Scottish ecosystem? So we are actually one of five safe havens in Scotland. Safe havens are the Scottish term for trusted research environments as a whole. We have a Scottish safe haven network up in Scotland and work very closely together to support research at a national level. We're together, each of us represents a different partnership with an NHS health board or more than one health board, and a Scottish university. And overall, we cover the Scottish population, which is 5.5 million people, including transient visitors into Scotland. We have supported a number of different projects across the Safe Haven network, and support at any one time more than 1,000 different researchers across the network in Scotland. So it's an extensive network that supports all different types of research. Together with Research Data Scotland, we support the Scottish Government ambitions here around digitisation of the health service, increasing data-driven policy and data-driven service improvement within the NHS, and increased collaboration, increased innovation. So we as a network are here to support that national ambition for Scotland. Um, from a DataLoch perspective, so we represent the southeast of Scotland. The population that we represent in our data is about 1 million people who live and visit Lothian, for whom we hold routine health data. So it's perhaps worth just stopping and talking about what we mean up here by calling something routine health data. What does that actually represent for us? Well, this is data that is collected as part of people's day-to-day interactions with the health system. So it gives a comprehensive view of somebody's journey through the whole system, including details of services that have been used, visits to hospitals or to GPs, treatments, medicines they might have received, test results, so much more. That raw data comes into DataLoch, and we, with the help of our clinical experts, make sure that it is research ready to support research on an extract by extract basis, and then can then be interrogated for acute or chronic conditions, clinical pathways, or services. So that's what we mean here by routine data. Why is this particularly critical for us in Scotland? Why are data services like this important, whether they're in Scotland or beyond? Well, our purpose is to enable data-driven approaches to the challenges that we face up here in Scotland and across the UK in terms of the healthcare system, supporting research, innovation, and supporting the NHS. We know that the pressure on the NHS is growing. Lord Darcy's report from 2024 now, so that a little while ago now, but it was the first time we'd seen that challenge articulated in data to the extent that that report did. So I don't know how many of you will have seen that report. I'm sure all of you have had a look at it, but it had 17 pages of summary, a full report of 160 odd pages, and then a technical annex that contained a significant amount of data about the services that was more than 300 pages. The first time really we'd seen something explored in that way in terms of understanding the health system. It had its flaws. So most of the health data was from NHS England rather than across the four nations. Only a small amount of it directly focused on social care. We recognise that social care is a significant part of the health system, so it shouldn't be ignored. But despite these flaws, the report really was the first attempt to push for a data-driven health system. And we know the challenge in Scotland is particularly acute. We have an aging population. We have more and more people living with more conditions for longer. And life expectancy in Scotland has stalled, as the graph on the bottom right-hand side shows. Healthy life expectancy equally has worsened since 2019, meaning that people in Scotland are living for longer in poor health conditions and are increasingly reliant on a stretched NHS and support from within their community or family. How does that materialize for patients? Well, limited preventative healthcare, challenges with diagnosis, particularly late diagnosis, patchy management of long-term conditions, long waits for elective care. There are deep societal inequalities that are exacerbated by the crisis we've seen recently in terms of health cost of living that we're actually seeing played out now in our health data. And we know that our social care system is under the same pressures, and it's a system that's not well understood. But Scotland also represents a unique opportunity. So we have in Scotland 14 territorial health boards supported by Public Health Scotland. In Scotland, we have 4.5 million people, as I say, all linked by what's called a community health index number. So that's a unique reference number for every individual that's using the health system in Scotland, meaning that we can link multiple data sets across those siloed systems. We have a history in the region of collaboration between healthcare and social care, academia, universities, which actually means we have data sharing agreements in place for an awful lot of the data that we require to understand this complex system. There are over 200 digital health companies in Scotland. These are companies selling products or services into the health and care market. So it's really a rich area for supporting research into the health system. Wanted to give you some real examples. It's always useful when we can look at examples of research and data that's being used within this context. So and I'll talk you through the slide. There's a few bits and pieces on this slide. This is a project that we were supporting with NHS Lothian to provide new insights into the primary care area for GPs to understand complex multimorbidity within each of the practice areas that we were exploring. The work has been led by the NHS Lothian team, where we have linked data to support an understanding of practice areas for GPs. On the right-hand side, we have a description of it's a description of the multimorbidities that exist across the region. So this is looking at the most prevalent conditions within the region, providing our GP practices with a view of their population in terms of those most prevalent conditions. And on the chart on the left, the stacked bar on the left-hand side shows how that complex multimorbidity interacts with deprivation. So this bar represents, each one of the bars represents a locality level in Lothian and uses SIMD, which is a Scottish index of deprivation, where the dark red represents the areas of highest areas of deprivation in the area. If we look at just the third bar along that particular locality, you can see that it has a high proportion of patients with complex multimorbidity in the most deprived areas. So close to 50% of those who have complex multimorbidity live in two of the most deprived quintiles here. Complex multimorbidity is potentially very helpful to understand in this, to target interventions within a population. We've also provided on the bottom right-hand side a view for GP practices about the amount of polypharmacy that exists within their region. So this is people who might be considered frail, so in this case over 75 years old, who are receiving multiple medications for different conditions and living with multiple conditions. Um, and we provide GPs with a view of who those patients are, and the GPs are then able to talk to those patients and review their medication to reduce the amount of medication they are on. This becomes particularly important as people get older, because actually the impact of being on multiple medications is particularly acute for people who are older and more frail. Just to give another example, again, working with NHS Lothian, DataLoch and an organisation called Cyrenians. This is an organisation that tackles the causes and consequences of homelessness. They support 7,000 people every year in the Lothian space. They have a hospital in-reach service within Lothian that supports patients who are homeless through a hospital stay and through a discharge process to find them accommodation to help with their recovery. We worked very closely with them, with NHS Lothian, to identify those patients who might be most at risk of homelessness during admission. So understanding people who are in temporary accommodation, for example, very challenging with such a transient group. We've also looked at to identify the interactions 12 months prior to hospitalization and following hospitalization to understand how we might better target interventions to prevent homelessness. The Cyrenians team have seen a reduction in readmittance to hospital for those patients of 69%. So it just again gives you an idea of how just through targeted interventions, by having better access to data, we can actually support policy and intervention policy within the system itself. The two graphs on the left-hand side just give examples of patients who have experience with the health service. The coloured shapes here represent the different touch points within the health service, enabling us to identify as people come towards a crisis point, and can therefore intervene to prevent those crises from overtaking them. Just to give you another example, this is a researcher called Olivia Swan, who's based in Edinburgh, who has been doing some research looking at children who are living in cold, damp housing and the impact of that housing quality on respiratory conditions for those children. This has involved linking data across multiple areas, so integrating geospatial data and health data, looking at energy efficiency in homes, looking at pollution levels, and linking that data so that we can understand the wider environmental context that these children are living with and the impacts of all of these different factors on their health. We know that cold, damp housing is associated to respiratory conditions, but what we don't really understand is exactly the impact that that is having. And we don't know what could be addressed by addressing the issue of underheated homes. Livy Swan has been exploring this both at a regional level within DataLoch, but also at a national level. She's very interested in understanding what interventions might keep houses warm, but does that then trap air within houses that could then increase respiratory infections risk from trapping mold, for example, in housing. So the significance of the policy here is not yet understood, but a particularly interesting piece of research that we're hoping will influence future policy in this space. We have another project that is actually a collaboration with the Health Informatics Centre, which represents east of Scotland as a safe haven. This is a project called Heal Scot, which is funded through the DARE UK programme. And this particular project has been looking at the links between geospatial data and health data in a slightly different way than Livy's project. The question that we are answering from a research perspective here is, if I'm born, live, work, and age in a deprived area, how does this influence my health? These two images show the two cities within the areas that the research will be studying, and the different colours again show the different areas of deprivation within those particular regions. And a research would suggest that more than 50% of early deaths can be explained by socioeconomic factors associated to deprivation. So where and how we live are the main drivers of our health and health inequalities. This project is going to explore the question by linking health data to housing data, to financial data and neighborhood data, focusing on geospatial health inequalities. And again, the research is going to happen within a trusted research environment. In this case, that will be within the trusted research environment at the Health Informatics Centre. So I really just wanted to give you guys a sense of some of the projects that can use routine data and are using routine data today. But all of these projects are listed on our websites. This is the DataLoch website where you can explore more. I myself am not a researcher. I run the service. So my role is very much about making sure I can enable the research, effective research. But we have a list of all the research we have enabled, as do the Health Informatics Centre on their website up in Dundee. And I'll stop at that point. Thank you very much for the opportunity to talk to you guys.